chest pain, shortness of breath, and how to examine the cardiovascular system. So these few weeks, we're going to focus on lung problem. We're going to talk about the common respiratory symptoms, and we're going to talk about how to examine lung system, respiratory system of the patient today. Okay, can you guys see my slide?
Can see your slide, doctor.
All right. So before I start, your exam is going to be next Tuesday, right? Right.
Yep.
So the exam question mainly will take out from the topics that has been taught before today. Today topic won't be included. So will be included from the topics up to last Friday. Okay. So I think not that many lectures since the beginning of the year. And last year and this year, I think only about 10 lectures, right? I think maybe less than that. So you guys can focus on that. Exam questions is a simple one, not too difficult. If you remember our tips, usually no problem. Okay? Okay, so let's begin our lectures today. Okay, so what we plan to for this lecture, in this 1 hour lecture, I want you guys to at least familiarize what is the common presentation of respiratory illness, what kind of symptoms that comes to you in the clinic, and how do we take relevant detailed history regarding that complaint, and how do we form a differential diagnosis, what are the causes of different symptoms, what are the common basic investigation we can order to investigate the lung pathology, how do we interpret the X-ray, just a very basic introduction, and how do we examine the lung, the respiratory system. Okay, so this is the 4 basics common complaint that you see in clinic, in hospital, in inpatient and outpatient settings. They can present with cough, very common, shortness of breath, be it acute shortness of breath happen very fast, or chronic shortness of breath, chest pain, and hemoptysis. We're going to elaborate in details regarding each of these complaints. Okay. So what can happen in our respiratory system? Hold on.
我已经有 refer 一个 case， 我看 setting like this。
That's a lecture. Hold on, let me settle referral. Sorry for the interruption. So there are few big groups of lung pathology that you need to be aware of and to know about. The most common that we're dealing with is still lung infection. It can be acute infection, bacterial infection like pneumonia. It can be viral infection, pneumonitis. It can also be a chronic infection like tuberculosis. Those are the common things that we see in Southeast Asia. And then obstructive airway disease. This is our airway. Our airway from trachea is a big windpipe. Then you will further branch it to smaller windpipes that supply the oxygen from your mouth, from the nose to the airway to your lung. So obstructive airway disease means it's a viral pathology that affecting your airway, that is causing it narrowing. Common that we are dealing with is COPD and also asthma. Okay, so COPD is something that you will see in the middle-aged or elderly patient, especially if someone has a prolonged history of chronic smoking, not just cigarette smoking, and be also in someone that use road vehicle. And now we are another new identity is something called e-cigarette, vaping, that can also lead to airway disease. Asthma is also an obstructive airway disease, where it's a congenital combined causes due to genetic and also environment exposure that can also cause obstructive airway disease. And then the other group is lung cancer, less common. Then pulmonary circulation problem, mainly we're talking about pulmonary embolism, blood clot in the lung vessels, and some other lung pathology like interstitial lung disease, which is not very relevant to you. Okay, so we talk about the first symptoms of that commonly we hear about, which is cough. So I think everyone here experienced these symptoms before. Um, so what could be the causes? What could be this cough means? So give you an example of 50 years old, is a chronic smoker, comes in with prolonged cough for 3 months, and this morning cough out with blood. So how do we know what are the differential with this cough? Everyone with this kind of age group come with cough the same or not? So that's what our history wanted to tell. So are all the cough the same? Someone elderly with a chronic cough for 3 months, or someone younger with a history of chronic smoking or chronic smoke exposure comes in with cough, is it the same or not? So give you an example. Let's say this someone 50 years old, chronic smoker, has been smoked for more than 20, 30 years, comes with prolonged cough, and then cough out blood this morning. Is it with same with someone who is similar age, similar background, but they are Bangladesh worker? What are the difference between the two? Anyone can answer?
Mm,
Any idea? What is the difference between 1 and 2?
I think number two. Oh, the difference is like you're asking for the disease, is it, doctor?
Yeah, they're both present with cough. How does it differ in 1 and 2? We just different in the Bangladesh worker. They're both cough. They're both comes with coughing up blood.
I have no idea, doctor.
Or
I
maybe
think number two, maybe it's regarding about his occupational, something like that.
so. What about number 3? Someone with 50 years old, chronic smoker also cough for very long, but this time it comes with wheezing.
If wheezing from the video, I think it's pneumonia.
What about number 4? Someone coughing also 3 months, but then this time the cough got white sputum, got some leg swelling, or some autopnea. So I'm trying to say that is that not all the cough are the same. Okay, so some of the cough characteristic of cough associated symptoms, and their social background can give us an idea how can they differ and what are the provisional diagnosis that we can get by just taking a detailed relevant history. Let me tell you further. Like for example, in this number 1, someone with elderly, smoke for very long. We all know, and then now come out with cough and cough out blood. So, what are the risk factor, or what are the things that chronic smoker can get? What are the most thing that we worry about with someone has been smoking for 20, 30 years? What kind of malignancy they will get?
Lung cancer.
Yeah, lung cancer is something that biggest risk factor for lung cancer. One of it is chronic smoking. So, with someone chronic smoker comes with coughing out blood, especially when the cough prolonged for 3 months, lung cancer is something that you're very concerned. Okay, but what if these 50 years old, not just smoking, they also come from Bangladesh? How does it differ? In Southeast Asia, some part of the country, the socio-economic group is still not very good. So tuberculosis is still something very common, especially in immigrant, because they do not have immunization, they do not have regular screening. So Malaysia is considered developing or even going towards developed country. Our TB prevalence is still quite high because of the influx of uncontrolled or those non-licensed immigrant. Those that comes in through proper channel, there will be X-ray done. There will be a tuberculin test done to rule out dormant TB. But those illegal one, they might have dormant TB, come into Malaysia, then they have a full-blown TB reactivation, and they spread the TB infection among their own population because their living condition is known to be very crowded, not very hygienic. So they tend to spread TB among themselves, especially in those uncontrolled conditions, like labor worker, especially that we are dealing with. So when someone is seeing those poor socioeconomic background, chronic cough with hemoptysis, always think of tuberculosis. What about number 3? Also chronic smoker, also coughing. But now there are other associated symptoms like wheezing.
COPD.
Yeah, so wheezing tells you it's a obstructive airway disease. So if let's say someone elderly only started to have develop this kind of symptoms, this type of story tells you maybe this patient has newly diagnosed COPD. How about number 4? Someone cough also, but this time the phlegm, the sputum is like whitish, pinkish. But patient has leak swelling and autopnea. What does this leak swelling and autopnea tell you?
Edema.
It tells you swelling, right? Swelling means what? There's too much what in the body?
Too much fluid.
Too much fluid, what do we call it? What scientific term that we use?
Pulmonary pneumothorax.
No, pneumothorax is air.
Oh.
So what is it called? Patient has fluid overload.
Pleural
Right?
effusion.
Overload is fluid overload picture, right? So leak swelling and autopnea, they are symptoms of fluid overload. So the fluid overload can be happen for different reasons. It can be fluid overload because of kidney failure. It can be fluid overload because of heart failure. So someone with heart failure can also give you prolonged cough because of pulmonary edema. Okay. What about someone with 50 years old, also chronic smoker, but the cough only 3 days? Yellow sputum fever. What does this fits into? This number 5.
Chronic bronchitis.
So when something very acute, you see something with a fever for a few days, what does this tell you? Is this more towards a malignancy? Is it more towards an airway disease, or is it more towards an infection?
Infection.
Yeah. So this type of history tells you that this patient has an acute infection, and patient has high-grade fever. It could be a bacterial infection. All right. So number 6, someone with a productive cough also 3 days cough with high-grade fever, but this time there are other associated URTI symptoms like runny nose and sore throat. So what does this tell you? So runny nose and sore throat, what are the symptoms are they?
Upper respiratory tract infection.
Yeah, correct. So this tell you that this is likely a URTI episode. So this is likely in viral cause of infection. All right. Although they are similar background, but the way they present, the other associated symptoms tells you that this could be a viral rather than a bacterial infection. What about number 7? Someone with a similar background, 50 years old, chronic smoking, also have prolonged cough for 3 months. But the other associated symptoms is like heartburn and a lot of belching, like burping and belching. So this could be because of reflux, gastric reflux, when the acid from the swallowing tract from your throat from your swallowing tract, your esophagus backflow, when the acid get reflux into your airway, it can lead to a laryngeal reflux. This can cause prolonged cough. All right. So there are so many, all 7 of them. This is just a small example. 7 of them similar age, similar background, chronic smoking, came with cough, but there are 7 different diagnoses. So it tells you that you need to elaborate, get more detailed, relevant history for us to, at least from the history itself, to give a differential diagnosis. What does the patient has? So those are things that we expect you to learn when you are asking questions. We expect you to try to elaborate this relevant history. So how do we do that? So when you face someone with when you hear something about cough, you heard patient complain to you about cough. So you want to know, the first thing is, what is the duration? Is this a acute cough less than 3 weeks, or is this something for very long, for more than 3 weeks already? Chronic cough is defined as cough that lasted more than 3 weeks. Usually acute infection, right, like viral UTI, bacterial pneumonia, they tend to be short lasting. They tend to comes with fever, and they tends to be lasted only about a week or 2. When the cough is something longer, so need to consider other differential diagnosis. Could be a prolonged infection like tuberculosis, and could it be some obstructive airway disease? All right. So besides that, when we hear about cough, we want to know, is this cough is productive or non-productive? Because productive and non-productive cough, they have different differential diagnosis and possibility. But when you hear of cough, always important relevant history is smoking, whether the patient is smoker or not, because the field pathology is very relevant to this smoking. One of it is COPD, asthma, and also lung malignancy. Okay, so how do we ask about smoking history? So in smoking, we want to know about how much, what do they smoke? Do they smoke a normal cigarette? Do they smoke a roll cigarette, or do they smoke e-vaping? Even e-cigarette vaping, those are potential harmful to our lung and our body. So if you remember the previous lecture, how do we count the pack years? So if let's say someone smoked 1 pack of cigarette, 20 cigarettes a day, that's called 1 pack. For 1 whole year, you smoke 1 pack per day. For 1 year, that is 1 pack years. If you has been smoking for the past 10 years, 1 pack a day, that's called, total is 10 pack years, right? That's how we roughly count it. So we can give a reflection on how heavy the patient smoke. Okay. That is for cough. Mainly is want to know the duration, whether it's productive or non-productive. Ask about relevant, whether smoking or not. There are other important causes of chronic cough that often people just forgot. Is postnasal drip or GERD refluxes. So if you have a very bad GERD acid reflux, it can lead to chronic cough. Especially this GERD causing cough will happen at night when you're lying down, lying flat. Because when you're lying flat, when you are sleeping, the acid tend to track down following the gravity. So this make the reflux more frequent, and patients sometimes can complain of waking up middle of the night coughing. But the cough tends to be dry, non-productive rather than productive. Okay, so productive cough, the common thing of course is still acutely is infection, pneumonia, chronic cough with productive phlegm, COPD, bronchiectasis, and chronic bronchitis. Those are things that we commonly see. Asthma, a lot of time their cough tends to be dry, okay, but their cough, later there's another slide talking about asthma. The cough in asthma tend to be associated with flame, associated with smokes, and associated with cold weather. Tend to have worsen of symptoms when they're exposed to all those gases. Okay. Other causes of productive cough, of course, don't forget about heart failure. Their cough phlegm tend to be whitish or even pinkish. tuberculosis, chronic infection can give you productive cough as well. Lung cancer, lung malignancy, their cough can be productive or non-productive. The telltale sign or the red flag sign that tell you this likely could be a lung cancer will be hemoptysis, something very dangerous when you have hemoptysis, and also weight loss. When someone has hemoptysis, constitutional symptoms, heavy smoker, always think of lung cancer. Other causes of non-productive cough, heavy smoking, asthma, reflux, and talking about ACE inhibitor. So, anyone know what ACE inhibitor is? I think this is,
It's AC inhibitor.
Angiotensin converting enzyme.
yeah, correct. So it's a group of it's a subgroup of antihypertensive where they inhibit this ACE. So what happened in this ACE is that it can cause it can increase the level of bradykinin. The pathophysiology is that when you take this ACE inhibitor, it increases a level of certain chemical in the body called bradykinin, and that bradykinin causing cough, causing the symptoms of cough in patients taking this ACE inhibitor. Not everyone has it. Probably talking about 15-20% when they're newly started on this ACE inhibitor, antihypertensive medication. Example would be like perindopril, enalapril. Commonly we use is perindopril. If let's say they have these symptoms, most of the time we will stop the medication and ask the patient to switch to other class of antihypertensive. Okay, so what are the main things that we need to worry about when we start ACE inhibitor? Exam tips. So when you start someone on ACE inhibitor, perindopril, anything that you need to ask the patient do after 1 or 2 weeks, anything you need to monitor. So the answer is renal function. When you're newly started on someone on ACE inhibitor, perindopril, you need to monitor the renal function in 1 or 2 weeks' time, because this ACE inhibitor can cause kidney impairment, especially in someone who has renal artery stenosis. So if let's say patient has renal artery stenosis, you start patient on the ACE inhibitor, the kidney function can suddenly worsen. So we do not want that. So whenever we start patient newly started on this medication, this group of medication, we will monitor the renal function. Or even in someone already known to have renal artery stenosis, this group of medication is contraindicated. You shouldn't start this patient on it. Okay. All right. So other causes of non-productive cough, remember chronic heart failure. Most of the time it's productive. It can be also dry cough. And of course psychogenic. So this psychogenic cough, they can have persistent complaint of cough, but it's distractible. Try to talk to them. When they're sleeping, they have no cough. When you're distracting them, the cough will be absent. Okay, so when someone with cough, we're thinking about asthma, or someone even with background of asthma cough with cough, there are a few things that you need to ask regarding asthma in detail history. So you want to know if patient has asthma, you want to know how is their control of asthma. Has there been on inhaler before, and what type of inhaler they are on, how frequent they go to clinic to get the nebulization. Okay, and if someone asthma good control now come with a cough, you want to know is the cough precipitated by something or not. Could it be a viral illness, any recent UITI symptoms that give you these symptoms? And is the cough actually precipitated because of cold and during rainy time or during cold weather? And want to know, do they wake up middle of night feeling during breathlessness or not? All this tell you the control of asthma. Okay. Usually in the asthma patient, they also has other telltale signs like a family history of atopy, where they tend to have easy allergy, they always have rhinitis, runny nose. Whenever after shower or cold weather, they tend to have this non-specific eczema and skin itches Those are the history of atopy that's suggestive of asthma. Their job is relevant. Patient has asthma, you want to know that they're smoking or not. Do they have exposure of smoke or dust at their job? Do they have pet at their home? Because the pet will shed, and the tiny fur can precipitate your cough. And not just patient smoking, if patient is living with someone else, like the partner, their parents, do their parents smoke or not? If they are smoking, do they smoke in the house or outside of the house? So this can tell you what type of environment the patient in that can exacerbate your asthma control. Okay. Okay, I think this is a bit repetitive. If someone with cough, with sputum, with breathlessness, acutely, of course, we think about infection. Patient with 1 week history cough with phlegm and shortness of breath, always think of lung infection first. Okay, if they are wheezing, think of bronchial asthma. If something has been prolonged, chronic, think about obstructive airway disease, bronchiectasis, and if they are also associated failure symptoms, always rule out heart failure or kidney failure. Okay, how about hello? Yeah, anything?
Doctor, can you repeat back the one that you said about heart failure and kidney failure?
Yeah, when someone with just cough, sputum, and breathlessness, besides the respiratory symptoms, you always want to ask, could always think in back of the mind, especially when this cough is chronic one, not few days, has been worsening, progressively worsen, more than 1 week or even months, and patient always think about heart condition. You need to explore, does the patient has also other failure symptoms like orthopnea, PND? Could the patient lie flat or not? And any leak swelling, that can tell you that patient is starting to have overload symptoms. So in that case, overload, it can be from your heart, can be also from the kidney problem. So you want to explore in that direction. Okay. All right. So next complaint is common presentation is shortness of breath. So a lot of times these type of symptoms, they just come alone one. So whenever you hear one symptoms, you always ask, if patient has cough, after you settle the cough history, you want to ask any associated shortness of breath or not. So you want to know the shortness of breath. I think very what does it mean like shortness of breath? Does the patient have shortness of breath when they are at rest, or the shortness of breath on exertion? So among progressive worsening of reduced septic tolerance or shortness of breath, actually associated more towards heart problem. Okay. And of course, you want to know the shortness of breath is acute or chronic or not. Does it happen just over days, or just happen over seconds, or has been happened over the past few months? So how fast the shortness of breath happen also can tell you something. For example, someone had a motorbike accident, fall down from the motorbike, after that had the chest pain followed by a severe sudden shortness of breath that developed minutes after the accident. So what could the diagnosis be? Any answer? Any answer? Anyone? Anyone? So trauma related, what happened? What could happen when you fall down from a bike? What trauma related things that can give you shortness of breath? At least give me 3. If let's say you are driving a motorbike, you fall down, and then you have difficult breathing, what could be the possibility? Okay, let's call some name. Haley Law.
Anxiety.
Yeah, panic attack. Don't forget, it's very very common when someone, especially never had an accident before. You can have a something very happen. You never faced this. You are in pain. You can have panic attack. Okay, although it's not respiratory pathology, but you can have panic attack because of this. Okay, any other differential? Nurul Aqua.
Yes, doctor.
What could be the show? Someone fall down from a bike, sudden shortness of breath, chest pain. Think logically, what could happen is someone fall down from a bike, now got a pain and difficult breathing.
Broken ribs.
Yes, you can have trauma to the chest wall. You can have broken rib causing pain. And the broken rib is sharp or not sharp? What do you think?
Sharp.
Yeah, when that sharp rib go and poke inside the lung, what will happen?
I forgot the name, but there's
Pneumothorax.
Yeah, correct, Mark. It's pneumothorax. So when something sharp poke your lung, you can have rough like a balloon. Your lung is like a balloon. Something poke it with it. Someone poke it with a needle. The balloon can explode. You can have a pneumothorax. If let's say you poke your lung, you're bleeding. You can have what's it called? Yeah, bleeding in the lung. So what's it called?
Hematoma.
Yeah, you can have a hematoma inside. You can have the effusion. All this can give you sudden shortness of breath within seconds. Okay, so if someone, so the time and onset is important when we're getting about the history. If someone just tell you, oh, has been for months or for years already having this shortness of breath, you know that something pathology has been going there for many years. It's not something very acute. So the differential is different. Okay. Okay. So common things is still common for shortness of breath, like your COPD, asthma, and then pleural effusion, lung cancer. All these can give you progressive shortness of breath. Sometimes some of the disease or differential you cannot get by just history. A lot of time, if you don't get too detailed history, when you take an X-ray, a lot of time you can get it. But if your history is detailed enough, you can get the history of airway disease. You can get the relevant history of lung cancer. So a lot of times they help to accomplish each other. You take a detailed history, get the relevant investigation done, and X-ray, you see something, it looks like mass, then you explore more history regarding relevance of lung cancer. Okay. Other causes of progressive shortness of breath, don't forget about anemia. So anemia help with your oxygenation. If you have chronic anemia, you tend to have progressive shortness of breath. Okay, you lose a lot of blood, you have shortness of breath. And blood clot, thromboembolic disease can give you difficult breathing as well. Right? Okay, so I think this covered what I said just now. Okay, this is something very uncommon in the adult, inhaled foreign body. So usually more common when you see this in kids when they put some body parts, not body parts, some toys part. That's why you see some when you play some toys before, especially those that smaller than your hand, that the size is small enough to be placed into an orifice of the body. They can be swallowed. They can put in the nose. You can actually see there's a specific label on, not suitable for the child below 6 years old or something like that, because they do not know what to do with it. They may swallow that toy and causing aspiration. That's why if you see something small toy, there always has this label because they worry of inhale foreign body. Okay. Not commonly seen anymore, but the telltale sign usually is the pits when they say that they put something in the nose, when they have persistent cough. Sometimes you may see trauma at the nose orifice, and patient may have a persistent lung collapse or persistent pneumonia at that certain area of the lung. Okay. Okay, next complaint, the common one is a chest pain. So what do we mean by pleuritic chest pain? So pleuritic chest pain is something we'll see as well, not as common as the first two symptoms. So pleuritic chest pain is just mean like the pain when it's triggered get worsened by a deep inhalation or movement of the thorax. When you take a deep breath in, your thorax you expand and move outward. That can cause the pain. That's called pleuritic type of chest pain. And usually pleuritic chest pain is unilateral. So when you hear of chest pain, these are the few things that you need to worry about. Someone young after a trauma always think of pneumothorax when it started onset. Okay, pulmonary embolism, when you have blood clot in the lung, can give you chest pain. Lung infection, especially with pneumonia with the effusion. When the pneumonia is bad enough, it can cause secretion, causing pleural effusion. So that will commonly lead to pleuritic chest pain. Because just not the lung, always think of musculoskeletal causes. Any fall recently causing a hematoma, rib fracture at the side of the chest wall. Because when you have a hematoma, you have bruises, you have fracture rib there. When your chest wall expand, you will have pain. Okay, and of course, other thing that don't forget sometimes is the skin lesion. Herpes zoster can also give you pleuritic chest pain. Okay, so talking about pulmonary embolism, thromboembolic disease can give you sudden shortness of breath, chest pain, can also give you cough, but predominant symptoms will be chest pain, shortness of breath. Sometimes they give you hemoptysis. So what is thromboembolic disorder that we're talking about? So this is our lung. This is just a diagram illustrates our lung. This is our vessels, IVC, and this is our heart. So what happened is that most of our blood vessels, all our veins, our veins is actually static one. So the pressure is lower. So the blood tend to be stasis, especially when you are sitting around, when you are not moving around, your blood tend to be staying at the peripheral. So this return of the venous blood actually depends on your venous pumping, your muscle pumping. When you're walking around, your muscle contract. This will squeeze the blood from the distal area, from the leg, will pump the blood through the IVC back to the heart, and that will pump the blood to the lung for oxygenation to become an arterial blood. That's what the normal cycle to be. So the circulation actually depends on a lot of movement. So if someone has been sitting around, not moving, especially on long haul flight, when they are bedridden, they tend to have blood clot form in the leg. So when that happens, when the blood clot accumulates big enough, they may dislodge at one point. If the clot is just staying here, not causing any problem, that's what we call deep vein thrombosis. Blood clot form in the deep vein is called deep vein thrombosis. It can cause leg swelling, pain, etc. But when the clots start to dislodge and they landed in the pulmonary vessels, that is pulmonary embolism. So pulmonary embolism can happen in the big branches and small branches. When the clot is big enough at the main trunk, it can have a lot of problems because when you block the whole blood vessel in one side of the lung, oxygen cannot perfuse into the venous blood. You can't get enough oxygenation, so you get hypoxia, you get difficult breathing, you get chest pain. If the blood clot has so lucky to be only block the distal branches, the symptoms may not be so significant. You may just have a mild shortness of breath, may just have a mild tachycardia. Okay. So what are the risk factors of forming this pulmonary embolism? Of course, immobility. No? So this back to something called Virchow's triad. No? I'm not sure if you've been hit before or not. For clot to form, Virchow's triad is something increase the risk. One is immobility. Number two will be hypercoagulability. Hypercoagulability, when someone is very dehydrated, their blood is very thick, they tend to form blood clot. And another one is endothelial injury. When someone has a trauma to the leg, vascular injury happen, the blood clot tends to form earlier and faster. So all this lead to the chances of forming blood clot. Okay. So pulmonary embolism, always think of this differential when someone immobilized, someone obese, someone has the risk like long stay, long bedridden, or long haul flight. comes in with shortness of breath, always think of pulmonary embolism. So examination, most of the time you just notice patient hypoxic, bit tachypneic, anxious. Most of the time you only can get tachycardia in examination. You do not find much findings on physical examination. Okay, another symptoms is hemoptysis, something very important as well. So what is hemoptysis? Hemoptysis means coughing out blood. So you need to be very specific in this term. Need to clarify with the patient. Do you have cough? Do you notice the blood when you cough out or actually vomit out? So some of the patients, they cannot differentiate. That maybe they have cough and then vomit, and the vomiters have blood. So you need to differentiate with the patient. Is it cough with the phlegm, then notice the blood, or is it vomiting? Hemoptysis is coughing out blood. Vomiting blood is called hematemesis, Heme. All right. So if patient is really having hemoptysis, you want to know since when? Is it a few days, few months, or just acutely happened? And want to quantify. Whenever you hear about symptoms of bleeding, you want to quantify how severe, how heavy is the bleeding. So is it just a phlegm mixing with the pinkish sputum, pinkish blood, or is it fresh blood that coughing out fresh clots, or small amount of fresh clot? So you want to quantify the size, because this can tell us how dangerous is the lesion and how fast we need to act to stop the bleeding. The patient say they cough out just blood streak, something is not so worrying. If someone say they cough out like 50 cents of clot, is something more dangerous that we need to admit and work out further. Okay, so common causes, infection, of course, is something you need to rule out. It will be tuberculosis, I mentioned before, especially with someone with low socioeconomic. In Malaysia, everyone hemoptysis, always think of TB first, okay? Especially with someone young. TB always comes with cough, shortness of breath. Hemoptysis may or may not be there, but constitutional symptoms like weight loss, loss of appetite, loss of weight will always be there. Okay, lung cancer, always some of the lung cancer will give you hemoptysis, depends where is the location of the lung cancer. Okay, and pulmonary emboli. So those are the four symptoms that you need to aware of: cough, shortness of breath, hemoptysis. Need to know about the differential diagnosis that I'm talking about just now. All right. So what common investigation that we expect you all to know about? Of course, number one will be chest X-ray. Whatever symptoms, the four symptoms patient have, you need to have a basic plain chest radiography. Okay. Next few slides, we'll talk a little bit about the X-ray interpretation and other investigation that can be done. Relevant will be CTPA. CTPA is the gold standard to diagnose a pulmonary embolism. When you have a suspicious of pulmonary embolism, the only test you need to order is CTPA. Okay. Lung function test is important to rule obstructive airway disease, such as the COPD and bronchial asthma. The patient have cough. If there is productive, you should stand for sputum examination, culture and sensitivity, and also for acid fast bacilli for TB. If all other basic tests is done, you still cannot get the answer, you think of lung cancer, you can request for high resolution CT, the HRCT, to have a detailed imaging of the lung field. And you can also do a bronchoscopy to look inside the bronchus and the small airway. Okay, so this is a normal chest X-ray with a label. We expect you to at least identify a major pathology in the X-ray. Okay, so when seeing the X-ray, you notice actually it's quite symmetrical, left and right. In X-ray, something dense will be white, less dense, will be gray. And if they are very, very lowest dense, they will, like the A will be black. So you see your bone will be white, your soft tissue like your fat, subcutaneous tissue, all this will be gray. Your A will be black in color. So always see left and right, are they symmetrical or not? If they are not symmetrical, could it be a pathology? Okay, that's how you screen for abnormality in the X-ray in one look. Okay, need to remember a few lines. This thing here is a trachea, it's always central. How do we know it's central or not? We compare the distance of your clavicle. This is your medial head of clavicle. You can see this is the end of the bone. This is the end of the bone. So the distance between trachea and these two is the same. If they are divided, one side is not. Okay. Then when they separate down, you can see the trachea actually divided into two, left and also the right one. If you notice anatomically, the left side here, actually closer to the right lung. The trachea actually closer when it branches. The right bronchus actually closer to the right lung. If you swallow something, the likelihood of the foreign object will be into your right lower bronchus here. So foreign body tend to land at the middle lobe or the lower lobe when they have mistakenly swallow a beads or something like that. That's where you look for it. Okay? Because anatomically, it is straight. When they swallow something, it fall down through the gravity, you follow this straight line and back to the middle lobe. Okay, so we have left and right lung. Left lung actually has two lobes, upper and lower lobe. The right lung has upper, lower, and also middle lobe. All right. So this comic line actually can tell you which is responsible to where. Okay. Next to the heart here, this is the middle lobe. Anything above the diaphragm on the lateral side is the lower lobe. And you have two dome shape here. This is your diaphragm shape. And wherever you have effusion, because of the gravity, the fluid will accumulate here at the lower part of the lung field. So when you have minimal effusion, you will lose the costophrenic angle. You will lose this angle blunted because of fluid accumulation. When you have more fluid, the lung will collapse. The fluid will form a meniscus sign. Okay, this is the normal X-ray. So what do you see here on the left-sided X-ray? Let's give some name. Oh, well, we are running out of time. Okay, volunteer. No volunteer. In front. What do you see on this photo? On this X-ray, the lower part is normal one. So what happened here? Is this symmetrical or not?
No.
Yeah. So what happened here? Which part is more hazy? So in X-ray, we don't use the word hazy. Hazy is something not so professional. We use the word opacity. Opacity, there's two types. It can be homogeneous, means it's all white. Heterogeneous means it's something white, but not so white. It's a mix of white and black. Like this, do you think it's homogeneous or heterogeneous? The homogeneous means something very, very uniform. Like all this white color, right? On my mouse here is homogeneous, everything all white. Heterogeneous is something like that. When you have see mixture in both. So is there opacity or not?
Yes, heterogeneous.
Yeah, so there's heterogeneous opacity in the right side of the lung. Where? So I have a reference here for you. So where do you think? Upper lobe, middle lobe, lower lobe?
Middle lobe.
Likely this one is lower lobe, I would say. Middle or lower sometimes depends on the X-ray rotation knob, but this one it could be middle and also lower lobe together because you see the hemidiaphragm here is involved. You see this hemidiaphragm is supposed to be lower lobe, right? You see it's affected already. And here middle also got a little bit. It could be a heterogeneous, or it could be a pneumonia of your middle and lower lobe pneumonia. Okay. How about this one? Similarly, you see some heterogeneous opacity, but this time it's confined in the middle lobe. Okay, you see the outline. This is middle lobe. What about this one? The third photo. Okay, let's find another victim. Satish.
Homogeneous, doctor.
What is this? What is this? What do you think? So if you look at the previous two photos, right, if it's a pneumonia, right, it tend to be like, if you think about it, a pneumonia of the lung, it's patchy infection, it become like this slope. But you look at this one, I think it's patchy or not patchy.
Non-patchy, doctor.
The whole thing like that, so what could this be?
Is it pleural effusion, doctor?
Yeah, this could represent pleural effusion, you see. So because you don't see the hemidiaphragm anymore, and then you see some level here. This likely will represent pleural effusion on the right side. Okay. So what about this one? Satish, still you. What about this one? Symmetrical or not symmetrical?
Non-symmetrical, doctor.
Yeah, what happened here? What is the thing that's striking elephant here?
There's like a vertical opacity.
Yeah, it's rounded, right? It's rounded, look like something round here, right? Correct or not?
Yes,
So
doctor.
in X-ray, we make it more scientific. Something whitish, we call it opacity. So there's a rounded opacity on your left upper lobe, right? So is it homogeneous or heterogeneous here, this one? It's all white, right? So it's homogeneous or heterogeneous?
Homogeneous.
Yeah, when it's uniformly white, it's called homogeneous opacity. So when you see something like that, always think of a mass. Always think of a lung cancer or lung tumor. In where? This is upper or lower lobe. So anything above the fissure, this is upper lobe, this is lower lobe. So this one is upper or lower lobe.
Upper lobe, doctor.
Yeah, so this could be a lung tumor in the left upper lobe. Okay, how about this one? This one a bit more tricky. For two. Let's see, let's pick another one. Mia. Mia, you're around. Mia not around. All right. So you see some homogeneous opacity here, right? You see it's rounded here at the right upper lobe, but something is like a straight line here. So why is it so straight? It's like you put a ruler, it's very straight. It's like a sea level. Like you have a fluid, you have a Pokemon ball inside has a fluid, and this exactly gives you a picture. So it tells you that there's an air fluid level here. So whenever you see air fluid level in a cavity, it's likely could be it's a cavitation. When you see cavitation, this could be an abscess, especially in the lung field. It's a lung abscess with the air fluid level in the right upper lobe. What about the last picture here, Mark?
Last picture.
What's wrong with the last? If you look at the previous picture, all these are black, right? Why this one so white, so congested one? Right now?
Oh, this is the one with the fluids, right?
Yeah. So what is it called?
It's called pleural effusion.
No.
Eh?
No.
Uh,
If you look at it in more careful, you see this heart is very small size, right? This heart is small or not? Quite small, right? This one is quite small, right? How about this heart?
it's big.
Yeah. So what is it called?
Cardiomegaly.
Correct. So there's a cardiomegaly here because there's increasing cardiothoracic ratio, and if you look at it, it's very congested. So what is it called? So we call pulmonary edema. You see some effusion, upper lobe diversion. If the X-ray is clearer, you see effusion and also curly V line. So this is a photo of someone with the acute pulmonary edema, fluid overload in the lung. Okay. Okay, so I hope you guys has gone through the video. We have very limited of time. So, hold on, I have a call to answer. Okay. Okay, so next 10 minutes, we're going to talk shortly regarding respiratory exam. Okay, I hope you guys gone through this video already. So let's go through together again. So in respiratory exam, the aim, if you look at the uh, detailed respiratory exam, is actually to try to pick up what is wrong with the lung. You want to try to guess what is the pathology that could be affecting the lung. Could this be a lung infection? Could it be a malignancy related? Or could it be some obstructive airway disease? Could it be a effusion? Those are things that we're trying to look for in the respiratory exam. Okay, so I'll just go through a running of the of this video. This, this is a very complete respiratory exam. So some of it may not be necessary to be done because you only have a very limited time in exam. So, but there are few things that you need to familiar with when you are doing a respiratory exam. So of course, before you begin, always wash your hand. Always get a consent before you started. Okay. So the first thing whenever you do what examination is, you want to inspect the patient first. You want to inspect from far whether there are any noisy. Sorry. Restart again. Can you guys see the screen?
Yes, doctor.
Yeah, you want to look from far, and you ask the patient to take a deep breath in. So from far, I want to see at the bedside, is there anything, any inhaler? Your patient has COPD or asthma, there will be inhaler around, any oxygen tubing around, and you want to see patient is actually taking or not. So you want to count the respiratory rate when you are standing far away at the patient. From far, if the patient has an obvious surgical scar, you should be able to see. And you want to listen for any other sound, any stridor or not. Yeah, so we'll start also from peripheral examination. You want to look for any peripheral cyanosis. Particular also, you want to look for finger clubbing, any tar staining or not. So tar staining, usually we look at the interdigital space. So the any yellow discoloration of your finger skin. Then you want to look for clubbing. Again, with the shamrock sign, you can look at the site. So temperature no need. We do not expect you to do this. It's an extra from this video. No need to do this. So just check the check the clubbing, check for tar staining. Then you want to see any fine tremor or not. When patient has regularly given inhaler, it give you a fine tremors. Then you want to look for hysteresis. So if you look at this video here, so this is called flapping tremor. So you put up the hand like that, and then you ask the patient to cock their wheel back and maintain it as it like that. So if patient has CO2 retention, carbon dioxide retention because of COPD, they will have uncontrolled flapping tremors. This is also flapping tremor is also seen in your GI examination when patient has encephalopathy. And then after that, no need to. You may or may not check the radial pulse, but you want to count the respiratory rate. Then you want to look for the JVP, whether JVP is raised or not. You have right heart failure because of a chronic lung disease, you have raised JVP. So face nothing much to see, maybe is to see any cyanosis or not. You want to check the conjunctival palate. You should want to check the pupil size because check the mouth, and you want to look for pupil size. I think it's not mentioned in this video because when you have a lung cancer, especially at the left upper lobe, it can cause a condition called Horner syndrome, whereby the mass actually compressing on the sympathetic chain in the upper cervical area. So that can cause Horner syndrome, whereby you have loss of anhidrosis, you have dry skin on the face, you have a small pupil on the affected eye, and you also have a partial eyelid drop. Okay, this is some extra. So after that, you want to focus on the chest wall. You want to look for scars. So where the scars going to be? Chest exam scars usually they are hidden at the side because the chest tube usually will be at this intercostal space. So thoracotomy scar, chest tube procedure scars, they're going to be on the lateral side. Next thing, you want to look for trachea, whether it's central or not. So you want to palpate for the trachea and compare it to the two head of the clavicle. After the trachea, you want to check for any deviation of apex beat. You started to have heart failure because of the lung problem. You have a deviate apex beat, and then only you will start to examine the chest wall expansion. So for chest wall expansion, because it will be clearer when you go to clinical exam in March time. So what actually this demonstrator do is you want to grab the chest wall from the lateral side, and then what you are measuring and seeing is actually at this finger. Your other four fingers grabs the lateral chest wall and ask the patient to deep breath in, and then you see the thumb how far they expanded and back to baseline. So normal chest expansion, you get around 5 centimeter anteriorly, and you will see actually they move equally to the side and then to the middle again. Let's see. Okay, so you do at the lower and the upper part. So at the lower chest wall, middle chest wall, and upper chest wall. Then followed by percussion. So percussion is to tell you whether patients normal percussion is actually resonant, means it's like hey like that percussing a empty field. If patient start to have pneumonia, the sound become dull. When the lung is filled with fluid, you have a stony dullness. So you start the percussion from up and then side to side, from up, top down, and move from side to side. And don't forget the lateral side of the lung field. Okay, so percussion is usually something that is difficult when you started to do examination because when you try to percuss yourself, you have no sound. So make sure your nail is short, otherwise you have pain on your finger. And then you need to keep on practice percussing yourself, percussing your friend. Then you started to hear some sound after you're hitting on the finger. And then after all the inspection, percussion, and measuring the chest wall, lastly only you get into auscultation. Okay, so in auscultation, there are a few things that you want to hear for. Number one is A entry. You want to comment on the A entry, whether the A entry is equal on both sides or not, whether is there any A entry or not. Okay, and then you want to comment on any added sound, any added wheezing or not. So you listen from above the clavicle and then only work your way down and to the lateral side of the body. So you listen twice on the axilla and then the tactile parameters, all that I don't expect you to know so don't worry about them. This vocal resonance, don't worry about it first. Just know about the basic like percussion and chest expansion. Just so after that, you want to sit the patient up, you palpate for the cervical lymph nodes. This is relevant, especially if thinking about TB, lung cancer, when you have lung malignancy, metastasis will start to develop to the lymph node, and those are places that they are seedling. So you want to palpate at above the clavicle, you feel for lymph node, and then you also feel the lymph node at the cervical, the neck, and the submandibular area. And after the anterior, then you want to move on to examine the posterior wall, just like what you did on the anterior chest wall. Start with the inspection, you proceed with chest expansion, percussion, and finally only you finish with auscultation. Okay, so that's how basic respiratory examination is. Okay, I'm not going to play the full video. So go back, you have time, play the video and again to familiarize with how to examine the respiratory exam. So this is just a further explanation if you do not get the details in the video above. Okay. All right. So cigarette smoking, you want to look for tar staining. It's not nicotine stain because nicotine is odorless and they're colorless. So the yellowish staining on the finger is actually from the tar. Clubbing, obvious clubbing in the respiratory system can be due to lung cancer, lung abscess. Okay, a flapping tremor signifies CO2 retention in someone with COPD. So the wheezing sound, I think you guys go through already. This play will be now familiarized with the added sound that you commonly that you will see in the ward. So wheezing you commonly see in COPD and asthma patient. Stridor is something you wouldn't see. Very rare to see stridor because they are life-threatening and they will not be stable enough for you to examine. So, but just familiarize with what is stridor. So you do not want to hear this, but if you hear one, you want to able to pick up it, especially when you're dealing with anaphylaxis. So someone with anaphylaxis, they will have sudden shortness of breath and stridor because of the airway narrowing. Just go through this after you watch the video, and yeah. So these are things that uh, this is the normal breath sound is vesicular breath sound, whereby our inspiration is always longer than expiration. So if you listen to the breath sound of your friend, you'll notice the inhalation is longer, followed by a very short and fast exhalation. When you started to have, when you develop pneumonia, you notice the breath sound of the patient become inspiration, expiration phase, they become equal, and the expiration tend to be longer. Whereas in patient with asthma and COPD, because of the obstructive airway disease, their expiration phase will be much longer with an added sound. Like this one. Then let's hear when I play the sound. Can I hear? Yeah, so you try to appreciate the normal vesicular breath sound. The the inspiration is actually longer and followed by a very brief expiration. Okay, this normal breath. You notice like this. Your in between your inspiration and expiration, there's actually no gap. You have a very long inspiration followed by a very sharp and rapid expiration. That is what the normal breath sound is supposed to be. Okay, let's try listen again. Spider, something. So in this previous sound, you notice the expiratory phase is actually longer, and then you hear added sound besides that. Let's try again. So that is what we call prolonged expiratory phase with added wheeze. Okay. So other sound that you want to be familiarized with is crepitation. You guys hear that? Can you guys hear the video sound when I play this now?
Video sound cannot hear, doctor.
Okay. Okay. So
No worry, we can
we play.
hear on.
So because I want this video actually quite good because the sound that they put in actually quite representative that you can commonly hear in the ward So pulmonary fibrosis is something you hear as well. The sound is like your Velcro. If you use that kind of Velcro shoe before, the kind that you use when you go to primary school, the white Velcro shoe. So that is the sound that you hear for pulmonary fibrosis. Okay, for lung crepitation, for fluid overload is like your your bubbles pecah like that. It's like when you have a lot of washing dish bubbles, when the bubble bursts, the kind of sound that you hear on crepitation. Okay. So okay, I think the rest I mentioned before already. I think that'll be all for respiratory exam. Okay. Any question? Any question for respiratory history taking and respiratory exam?
Doctor, does this chapter come in the mini test?
No, this lecture excluded. So you
Okay.
end with the last lecture.
The previous one.
Correct.
Okay. Thank you, Doctor.
I actually give you 3 tips in this lecture already for the upcoming exam. So if you listen,
Doctor, can you repeat the tips?
too late already. It's past already. I can only tell you. I give you a tips now. I put up an ECG photo inside. Okay, so
Is it the mini test or this one, doctor?
mini test lah. I put a BCG photo in the mini test. Okay, that's the only thing I can tell.
For,
Any
for
tips for
essay or
essay
objective,
presenter?
Sorry.
is the ECG in objective or essay?
Oh, very simple one. Don't worry. It's in the SAQ.
Oh, okay. Thank you, Doctor.
A very simple one. I'm going to think very fancy one. Okay. So our question is very simple one. I try to remove all those not very relevant, very difficult. So if you cannot think, just boring lah. Don't empty it. If you do not know what to put on that short answer questions, don't empty it. Just tembak anything. There's no negative marking one. If you think logically, you get the marks on. Okay. And MCQ also not too difficult, only 20 questions. And the answer actually most of it quite obvious one. So don't tembak, I think should be able to get on. Not too difficult one. Hopefully not too difficult. If you reflect to me after your exam, whether it's difficult or not. I feel it's not difficult. Okay, any other questions? Any other thing you want to ask? If no, then we end our lecture today.
Okay, doctor. We take picture of attendance.
Okay.
Haley, Hingma, Mia, Shana. Mia and Shana? What about Larissa? Okay. What about Mia? I say 1, 2, 3. 1, 2, 3. Okay. Thank you, Doctor. Thank you.
Okay, bye-bye.
Thank you, Doctor.
Thank you, doctor.
Thank you, Doctor.
Thank you, Doctor.